I'm Dr. Mohammed Sattar. I'm a GP, first and foremost, something that I absolutely love. I'm also a radio broadcaster on community radio just down the road from here, a station called Radiation Fever 107.3. It's a community radio station. And I'm also a clinical director for Chapeltown Primary Care Network. I am Pakistani by background. My ethnicity is Pakistani. I was born in Bradford and then I grew up in Leeds. And growing up, I was from a working class family. My dad was a businessman. We had a shop and my mum helped my dad run the shop, and we grew up in the shop. So we always participated and helped mum and dad, whether it was the paper round or it was mopping the floor at the end of the day. And I watched my mum help my dad. She's somebody who never went to school, but she learned English through her customers. She learned how to count because the customers helped her. And she was like one of my biggest inspirations. She used to cook in the kitchen at the back. There was the bell that used to go for the door at the shop, and then she used to run from the kitchen to the till, serve the customers, and then back again. And Dad used to do other things to help us to grow and invest in us. I had a really good education. My dad invested a lot of money and time in that. I was really lucky to go to a good school. I used to travel actually from Leeds to Bradford, 11-year-old with a rucksack. And that was my life, like for 5 years. I got some really good GCSEs, and then I went on to do A-levels at the local city college in Leeds, where I thrived. I loved it. So it was a mix of people, kind of opened my mind. It helped me to be independent. And I was really lucky because I met some really good group of people who were very driven, very studious, very academically bright. And it was really obvious what else was I going to do but become a doctor. And I think a lot of that's cultural because, like, if you're from a Black or Asian family, then there's a few options open to you normally. And luckily that's changing. I think that is changing now. But back then it was like you're either going to be a doctor, a teacher, an accountant, a nurse. And actually nowadays, especially on my radio show, I push for people to think outside the box, that actually those are not the only professions that you can do. And actually, whatever we do, we need to be in those spaces as people from like Black, Asian, minority ethnic groups. And actually, when we're in those spaces, we've got to be the best. So that's like what I try to tell people on air and people that I meet. But it was the obvious choice to be a doctor. And I've really not looked back. I love talking to people. I'm a real people person. And I always wanted to make an impact on people's lives. I wanted to do a job where there was a ability to make a difference to the world and to my community in a good way. So being a doctor helped me to do that. Being a GP was a very specific and conscious choice. I actually initially wanted to be a surgeon. I thought this is really, really quite cool, being in theatres. But after doing it for a year, it was fabulous. It was really transformational. It really pushed me. I looked after a lot of sick patients. I had a lot of time in theatre. I had some fantastic mentors. But the time that I loved was when I saw people before their operation and after their operation in outpatients clinic. And then I realized that actually my calling was with people, being able to consult with them and use my ability to communicate with patients and connect with patients. And general practice was absolutely the right choice for me. So I love it. I love being able to look after patients from cradle to grave. I take great pride in being able to provide that really high quality family experience. And even the surgery that we're sitting in right now with our branch surgery, and I thought about everything. A few years ago, we needed to upgrade, refurbish this place. And I thought about the patient experience. How do they feel when they are in here? And that might be what's on the walls, the sounds that they hear. And so we consciously try to make this an inviting space, but also that really warm feel. And every week something amazing happens for me as a GP. Been here for nearly 10 years now, and you get to really know your community. And you go to people's houses and make an impact on them. You help people through difficult periods, happy periods, people who have a real illness. You connect with families and patients on a scale and a level that I don't think you can do in any other specialty. It is the best job in the world. So we're at a time whereby data is everything. So we know what is happening in communities. We can ask for the data. We know the numbers. We know what our impact is. We know what the problems are. We can measure those and try to understand those. And through that process, we have infographics. We have the numbers that are telling us quite a lot of problems that still exist in our patch, Chapeltown. Chapeltown is a very diverse place. Half of people are living in the most deprived communities, and it's a fairly young population. It's got a lot of good work that's happening, but we've got some real challenges, and they include things like poverty. They include severe mental illness. They include higher rates of diabetes amongst other communities that exist in Leeds. And for the first time, we're now understanding the data for our young people and children. And I think that is where we really need to start focusing on. They are our future, but we see how many people need free school meals. We see the levels of obesity, mental illness problems, and I can go on and on and on. What that has meant is that we need to start to really focus on what I say is leveling this playing field, and really thinking about when we set up services, that those services are going to really meet the demands of our patients. What we're going to do somewhere else is not going to work in Chapeltown, and we need to talk to the people of Chapeltown, our people, our population, so that we can hear and really do the right thing for them. I think the reason that we're still in the situation that we are in is multifactorial. I think there's no doubt that poverty kills. People in Chapeltown live less, and a lot of that is due to income. So I think we need to address that, and we need to start at that really, is how can we help people become economically thriving, so that actually they are able to take better care of themselves. And that's where we need to start to begin. And they need equal opportunities. One of the things that I'm really proud of in Chapeltown is our Department for Work and Pensions Work Coach offer. It's a pilot. It started in 2018. I went to a meeting and they said, look, you could have a work coach in your practice, and they'll help your patients if they're never worked, if they're out of employment, or if they're having problems at work. I thought, this is a fabulous idea. Let's get the work coach into practice. And we have had so much success from this scheme. And they make such an impact on patients' lives, I can't begin to tell you. They are able to get you a new suit if you need one. You know, if you're not good at an interview, then they're able to get you a taster day so that actually the manager can see what you're like. If you're having difficulties from an occupational health point of view and you want to work, they can set up a assessment for you and make some recommendations so that you stay in work. They can put you on a course and pay for your travel. And this is an amazing thing. And I really believe in it. I think getting people into work and giving them a reason to get up, giving them a disposable income is really going to help them improve their lives and their well-being. They'll be able to go off and go swimming and, you know, buy a gym membership and, you know, the trainers that they need, and good food, wholesome food. So I think that is something that we have been focusing on. The other problems I think that we have is that we're still learning about the barriers to health, and I don't think that we've got it right. People tell us about distrust. People tell us about how our ways of access are not working for them, and that might be due to a language barrier and not having access to or not being able to access language line, for example, or interpreting services. And, you know, the statistics are that 48% of working age people find it hard to navigate the health and social care system. And that's working people. So, you know, I think if you're living in deprivation and you may be less aware, less in touch, then I think you have no chance. So we focus on that as well. We have an amazing social prescribing team, a well-being team, and a lot of their role is around social navigation, social prescribing. Other things that people tell us in terms of health is if you're living in deprivation, it means that you're more likely to be working nights. You might be working weekends, and most of our services are Monday to Friday, 9 to 5. So we've got to be a little bit more flexible in what we're offering, and we've got to be able to reach out to the community and do things differently in different spaces, perhaps. And I think there's no doubt from a service point of view, from a income point of view, from a funding point of view, staffing point of view, we've gone through the pandemic. We have lived through austerity. There's cuts, not enough funding to be able to really do things with impact and be able to do that sustainably. Often you might be given a pot of money, it might be last minute, and also it's non-recurrent. So how can you make sustained change when there's that type of offer for you? So I think we need to really refocus what we're doing, really back it with the real money, put money where our mouth is, and try to invest properly so that everybody wins. Mental illness is one of the most common things that we're seeing as GPs. Everybody will resonate with this. Everybody will have something common with this who's working as a GP, and actually beyond, whether you think about the police, the ambulance service, whoever you are, social workers. Mental health is such a big thing at the moment. But what's unique to us, if I could say, would be that we have a severe mental illness. So we have people with more extreme mental health, not just a sort of mild to moderate depression, but actually psychosis, just being an example. And what that means is that our response needs to be different. and we're well aware of that. So in Leeds right now, we have a primary care mental health team that consists of therapists, mental health nurse. There's some links between sort of more intensive psychiatry services and also the more sort of soft touch, if I can call that, sort of talking therapy services. That offer started off in Chapeltown. It was a pilot. We drove that in Chapeltown and saw that it works. Having these people in surgeries and working directly with primary care makes a real difference. So that was rolled out. That's one of the legacies of Chapeltown Primary Care Network. Back then it was called the locality, and this has been rolled out. And I'm pleased to say that most people in Leeds have access to a primary care mental health team. What that has meant is that their workload has increased and there's now waiting lists, and this is a common problem for most of the services within the health service. The other thing that we did was we were given some money to tackle what we call health inequalities. So when we talk about health inequalities, I guess it's an unequal chance, it's an unequal ability to be able to access services, to improve your health. And the reasons for that is multifactorial, as we've mentioned. And so this money was given to us so that we could focus specifically on Black mental health. That's what we chose. And we chose that because of talking to the community. So we went out and we did some focus groups, and the community was telling us that Black men's health is a problem. It's a real issue, and there's loads of things that came out in those focus groups, some really rich information, and they're things that will be familiar to us, things like barrier, stigma. But what was shocking for us was the rates of people who are sectioned and they belong to a specific community, which is higher in the Black community and higher if you're a Black man and a young man. And that was shocking for us. So we got to work and we were able to come up with a way of trying to help. And we did that through offering some micro grants. And depending on what your proposal was, you were allocated some funds. We were really lucky to work with 3 organizations, and they did something different in their respective fields. Third sector organizations, or if I could call them the first sector, because they really are first class. The charity and voluntary sector are working increasingly closely with the NHS, and I think we could not do our work without their help. No doubt at all. So I'm really pleased that we were able to offer some money, but again, it was non-recurrent. But some great things have happened from that, some real impact on the local community. But what has also happened is that future projects have been born from these 3 organizations working on this initial project, which has been really, really good. And I think for us as an organization, as a network, we're now thinking about, so we really liked working with these organizations. We can see the impact that they've had on this specific type of work, this specific population and demographic. How can we make this a bit more sustainable with the pots of money that we've got? And how can we harness this together working for third sector who really know their community because they're embedded in the community to make a real difference? So that's a little bit about what we've been doing around severe mental illness, particularly in Black young men. We worked with 3 organizations. I was so proud to offer these micro grants, and we went through a really specific process for that. We didn't make the decisions. people were invited to make applications, and then we asked another organization to run that process for us so that it was fair and equitable. We worked with Feel Good Factor, we worked with Chapeltown Youth Development Centre, and we also worked with Carmen Centred. And the biggest thing for me from those three organisations working together is that they have established some closer links. These are organisations that are embedded in the community. They really understand their communities. And I'm really pleased to say that they've been able to now take some work forward which is beyond the work of the microgrants. And I think that that's probably the lasting legacy from what we've done in terms of the microgrants. I think the other side to this was that we held back a little bit of money, and we decided that we wanted to deliver some training. And our health inequalities lead, Dr. Natasha Gordon, did some cultural competency training. So we were able to deliver this to the majority of our staff. We employ between 60 to 80 staff at a time, and a good number of those people, our staff, have a increased awareness of cultural competency. And I hope and I see that in the work that we do. So when the patient comes through the door, we talk to them on the phone, we're answering the email, we're trying to meet their needs. We're able to do that in a more aware, compassionate, empathic way. They say there's no business like show business, and it's absolutely true. I've been doing community radio for a number of years now, and I can safely say that it saved my life, especially over COVID, where it was a particularly difficult time. It was my way of being able to chill and go into a different world. I was able to go into the studio when it was allowed to, and because of lockdown and the restrictions, but most of the time we were solo working, we were able to go into the studio and broadcast out to our community. And it was such an important time because there was so much misinformation. And I felt so lucky because I had information that was at my fingertips. There was a lot of information. I was very close to what was happening. And I was able to reach out to our community in real time. And there was a real focus on the COVID pandemic and how we could keep ourselves safe, but also around the vaccines and hesitancy. I was able to share some specific information about everything from the deaths to hospitalizations to where you can go to get help. But also it was a time where people were isolated and lonely, and it was a really scary time actually. So not only was I able to give information like that, but also I was able to entertain people, and that really brought me a lot of joy. When I sit in the studio, I just go into a different world. I use a different part of my brain, the creative side of my brain. And I've already said I love talking. And so I'm able to use my skill, and actually radio has improved my ability to communicate, and it's also pushed me to think about my culture and where I'm from. When I was invited to speak on the radio, it started off as do you want to do a doctor show? So at that time I joined a fellow psychiatrist. He used to run the show and I was his guest, and we used to pick a topic and talk about it. Now, the show is less about information, although it's still important for me to use the platform to be able to educate, inform, and inspire people around social, educational, and health matters. So often I invite people to come along and they're experts in their field, and it might be a food bank, it might be a doctor, it might be somebody who's putting on a show or a film festival, or it can be anything. And I ask them to talk about whatever they want to talk about for half an hour of their time, and we get a really good response from people. So the focus is still that, but that's wrapped around the incredible music and the information that I try to give people around the culture and the Pakistani culture. It's a community radio station, and that means that we're not for profit. It means that we're different from the commercial radio stations. And it certainly means that we're completely different from the big broadcasters. We don't have the funds to be able to do some of the things that they do, but we still aim to reach out to as many people as we can. And some of the statistics say that we reach out to nearly 100,000 listeners. That's our reach across West Yorkshire, online, on FM and on digital radio. So that's a great reach. And I would say that the beauty of community radio station is that it's at the heart of the community. It's part and parcel of the community. People can come into our studio and have a cup of tea, and often they do. We have an open day and people come and have food with us. We raise thousands of pounds over the month of Ramadan, which is the month of fasting, as a radio station. So as a community radio station, we go beyond just broadcasting, but we really connect with the community. We take part in community initiatives. We lift the community. We inform the community. We're there. I think the future is not going to be easy. I've explained some of the challenges that we've got, the ongoing inequalities, the difficulties that our people face. I think we're starting at a good base. We've got frameworks and some legends within the system that are doing some really good work. So we've got initiatives like the Core 20+5, which has really highlighted certain groups, populations and illnesses that we need to really, really focus on because people miss out on those. We have got to start thinking about the public health message. I think that's lost. And I think until we think about that and take some real ownership of that and invest in the public health message, then things are not going to get better. It starts from what we call the social determinants of health. And what we mean by that is how much money you've got, access to food and education. And I think that's where we need to go back to. What is good health? I don't think good health is in the GP surgery. It's outside in the places that we live and work and pray and eat and sleep. And I think we need to focus on those. I think that we need to start to use the assets within our communities. There's some fantastic work going on in the communities at the moment. And we need to collaborate more with those organizations and those amazing people so that we can do great work together, because the health system can't do this alone. And I think we mustn't forget the people that we serve. And those are the most important people, the patients. Now, I think at the heart of every decision that we make, we've got to think about the patient. We've got to think about the patient. So those are my recommendations. And I think we shouldn't lose hope. We're starting at a place of good work. We just need to build on that good work. And that means collaborating, it means listening, and it means compassion. We've got to not stop caring. And if you stop caring, it's time to move on.